Good morning, everyone, and welcome to my grand rounds. My name is Taeweon. I'm one of the third-year urology residents here at the University of British Columbia. And like Dr. Gleave said, I wanted to focus my topic on the discussions around targeted biopsy and its utility over the last few years in the evaluation of men with clinical suspicion of prostate cancer. And I wanted to specifically focus on a specific population, the men that are getting referred for evaluation of prostate cancer, specifically in the biopsy naive setting. As a result, the objectives I wanted to talk about through the talk is discuss the rationale for targeted prostate biopsy and sort of examine why there has been this paradigm shift away from systematic biopsy, not necessarily to replace it per se, but how the targeted biopsy has sort of augmented the diagnostic pathway in men undergoing a workup for prostate cancer. And subsequent to that, we'd talk about some of the important landmark trials around targeted prostate biopsy and review briefly at the end what are some current recommendations in prostate cancer detection and biopsy naive men, specifically looking at the most recently updated European consensus and the statements from the National Comprehensive Cancer Network. And I wanted to preface the discussion by talking about or discussing the long-term benefits of prostate cancer screening. And now we're getting more long-term data from European trials that population-based PSA screening improves mortality. And these are trials that are reported up to 2 decades of follow-up in offering PSA screening in men from the age of 50 every 2 years to a range of every 2 to 7 years. And they're reporting mortality benefit from a reduction of up to 35% in their 18-year follow-up. But what is also occurring with this observed reduction in mortality is you're also getting an increased incidence of prostate cancers that are being detected, and this is perhaps where the catch-22 lies, is that with increased mortality benefit you're seeing with population-based screening, you're also detecting prostate cancers that otherwise would not have been detected, and the European group reported up to 1.4 times the increase in their incidence. And if you look at the breakdown of the diseases that are being diagnosed, the majority, or at least half of them, are considered over-detection, or the ones otherwise considered low risk that treatment wouldn't be otherwise recommended. And ultimately the problem with over-detection of these indolent cancers is that invariably risks the risk of overtreatment. And a hypothetical model that was devised by using a subset of the Dutch group from the European randomized trial estimated that half of the diagnosis they would detect through PSA screening in men between 55 and 67 would be considered over-detection. So detection of cancer that otherwise would not have been detected in the absence of screening, or ones that otherwise would have been left alone without benefit of any active treatment. And even looking at the large population-based data published in 2012, where they identified more than 330,000 prostate cancers that were otherwise grouped into grade 1 or Gleason equal to or less than 6. 34% are undergoing radical prostatectomy, with even higher proportion undergoing radiotherapy. And as you can imagine, with the risk of overtreatment also too, is that it necessarily confers the treatment-related morbidities to patients. Studies looking at self-reported quality of life of patients, while the long-term data might suggest that the reduction in quality of life is transient, but they do commonly report issues with their sexual function, urinary symptoms, and bowel dysfunction related to undergoing treatment. And this knowledge that the reason why the problem of over-detection is getting magnified is that we're increasingly being aware that not all prostate cancers need to be treated. This was a randomized controlled trial from the UK group under the name PROTECT, where they offer PSA screening to more than 80,000 men. They detected more than 1,600 localized prostate cancers. And when they randomized to unequal ratios to active surveillance or treatment in the form of radical prostatectomy or radiotherapy, they actually reported that cancer-specific survival exceeded 98% in all groups, regardless of treatment assigned at a median 10-year follow-up. So this really added to the idea that not all prostate cancers need to be treated, especially the ones that are being detected early through screening. This was further corroborated by Dr. Klotz and his prospective cohort study in Toronto from '95, where they, using a sample of 993 men with a localized prostate cancer, the ones with what they deemed low to intermediate risk prostate cancers demonstrated it was essentially non-lethal with actuarial cancer-specific survival 94% at 15-year follow-up, and the probability that you pass away from non-prostate cancer-related death would be higher in this cohort. But what I wanted to really bring up with these with this context is that the management around prostate cancer is only as good as your initial biopsy or any subsequent biopsies that essentially characterize the tumor biology. And this is the multivariate and this is looking at clinical factors predictive of requiring intervention in men undergoing active surveillance for localized disease. And you can see the ones that are highlighted, the predictors of treatment are essentially or very intimately related to the characteristics of the prostate biopsy that is being offered in either at the initial diagnosis phase or confirmatory biopsies that follow. So there lies the ultimate significance of prostate biopsy, is that it not only enables the detection of prostate cancer, but it also enables clinicians to accurately characterize the tumor biology, thereby enabling appropriate risk stratification and therefore recommending most informed most informed management based on an individual's risk that is being determined through biopsy. And the way we have sampled prostate in the past, or at least the traditional way, has been the systematic biopsy. And that continues to remain the standard of care in the diagnosis of prostate cancer, according to the most recent updates from the European consensus as well as the NCCN. And the extended sextant template, the so-called 12-core template, is the traditional template that's being recommended. These refer to biopsy techniques, deploying the needles more laterally towards the peripheral zone to increase the sampling, with the evidence that the previously used template, the sextant template, risk undersampling. But there lies the pitfalls of systematic biopsy, that it essentially entails obtaining tumors in a sort of a predefined systematic template that is fundamentally non-targeted. And with this risks sampling inaccuracies, and the data from systematic review would suggest that systematic biopsy misses 20% of any grade prostate cancers and a higher proportion of clinically significant prostate cancers. Sampling inaccuracies lead to possibly misclassification of disease, which is not uncommon. Up to 36% of systematic biopsy that was obtained through a 10-core template was upgraded at the time of more than 7,000 radical prostatectomy specimens for which preoperative biopsy information was available. And of course, this uncertainty around the diagnostic accuracy of the systematic biopsy confers the risk of requiring subsequent biopsies when there's a clinical suspicion that the cancer was missed. And with repeated biopsies too, you necessarily incur the risk of prostate biopsy-related complications. While the literature would suggest that the risk of biopsy is generally self-limited, perhaps the bleeding limited to the lower urinary tract, or transient urinary symptoms, or reduced erectile function, but you can incur the risk of serious infectious risk. A pair of Canadian series have looked at this retrospectively, and the Toronto group published it in 2010. That the risk of requiring hospitalization within 30 days of trust biopsy increased from 1% in 1996 to 4% in 2005. And most of these hospitalizations they were able to identify secondary to trust biopsy were infectious in nature. Independently, a Quebec group a couple of years later published that the risk of post-trust biopsy infection was rising, and partly secondary to the rising incidence or the detection of fluoroquinolone resistant gram-negative bacteria, more commonly E. coli. Perhaps adding to the fact that the standard prophylaxis is being circumvented by these antimicrobial resistance. What I didn't include here was also a systematic review evidence that was published in 2017 that also showed that men undergoing trust biopsy, and if they were to obtain a prerectal swab, that up to 30% of them would be fluoroquinolone resistant. So there goes the rationale for targeted biopsy is essentially the central goal of maximizing the detection of clinically significant cancers while minimizing detection of indolent cancers. Being able to characterize perhaps a targetable lesion with pre-biopsy imaging, and rather than deploying the needle in a systematic, albeit random fashion, being able to direct the needles to a targetable lesion. And before I talk about, go on to talk about the trials of targeted biopsy, it should be said that the imaging guidance of prostate lesions has been sort of foundational in this paradigm shift. And you see that the diagnostic pathway incorporating image guidance, especially with the help of a multiparametric MRI, is increasingly adopted. Briefly about multiparametric MRI is that it enables the characterization of both the anatomic and functional sequences of the prostate using very specific sequences. And there has been a lot of emphasis on being able to obtain MRI images sort of in a standardized fashion so that it can be applied broadly across the globe. And the specific anatomic phases that enables delineation of prostate lesions includes T1 weighted images, particularly helpful for delineating any evidence of post-biopsy hemorrhage, delineating the gland boundary. With respect to hemorrhage, it can be a mimicker malignancy, which can raise suspicion of false positive. The T2 weighted image is so-called the workhorse phase of the multiparametric imaging, delineates the prostate zone anatomy, especially abnormalities in the transition zone, which has been historically difficult to establish using the standard transrectal ultrasound. The functional sequences are just as foundational in sort of the minimum criteria multiparametric imaging, diffusion-weighted imaging, so sort of on the basis of Brownian motion, which referring to the motion of water molecules or diffusion across any tissue, which is reported to be restricted in any tissues harboring malignancies. And this is also the basis for a fusion apparent diffusion coefficient, which is reported to inversely correlated with the Gleason pattern. Finally is the dynamic contrast imaging, which relies on the T1 weighted imaging and renders images pre, during, and post gadolinium enhanced contrast exposure, particularly used for detecting small as well as non-malignant causes. The current consensus is that either a magnetic strength with 1.5 or 3 Tesla is accepted. The use of endorectal coil is not routinely recommended. And like I said about the increased standardization of the way we're reporting the prostate imaging has been the synthesis of the PIRAT schematic, which incorporates these minimum criteria to render a score. And again, this was essentially the central aim of this was to design to facilitate not only the standardized acquisition, the way in which we obtain prostate lesions, but also the interpretation of the MRI. The lesions are essentially ascribed a score out of 5, indicating the likelihood of harboring clinically significant disease on histopathology without incorporating any clinical parameters necessarily. And the clinical significance that the consensus has agreed was tumors with a Gleason score greater than 7, or tumor volume exceeding 0.5 cc's, or any evidence of extraprostatic extension. Several renditions of PIRADS have been published since 2012. The initial version in a systematic review had a pool sensitivity of 78%, specificity of 79%, when they primarily looked at an outcome of clinically significant cancers. There was a relatively smaller head-to-head comparison of the newer PIRADS 2 version 2 with the original version. When they looked at the outcome of detecting anal cancer, while the sensitivity of the version 2 improved to 95%. The specificity was relative. There was no improvement in the specificity particularly. Now, we discussed the minimum criteria for multiparametric MRI, and there has been a study that looked at whether these sequences are adequate, or how well these sequences do perform on its own. I'm not talking about MRI with the subsequent biopsy, but the MRI actually incorporating the anatomic and the functional sequences that we discussed. And in 2014, a meta-analysis looked at studies only inclusive of the minimum multiparametric MRI criteria, and they compared this against histopathology from a radical prostatectomy or a TRES specimen. And you look at what's highlighted here is a pool sensitivity of 0.74 and specificity of 0.88. It does perform moderately well in detecting any prostate cancers. However, interpretation of a meta-analysis like these or similar systematic reviews, and especially in the targeted biopsy literature, there's a marked heterogeneity in not only the clinical population that is being studied. For example, not everyone is biopsy naive. Some men have had a prior negative biopsies, but they're often compared against variations of reference standard, radical prostatectomy specimen or TRUS specimens. And this particular meta-analysis was published predating PIRADS. So the way they ascribed MRI risk did not have the benefit of the standardized PIRADS schematic. And this variation, I think, as such, also reflects that there's a prevalence in prostate cancer being diagnosed, or any clinically significant cancers being diagnosed using this criteria, also contributing to the wide range of negative predictive value of using these sequences. Currently, the way the targeted biopsy strategies are performed, there's 3 main strategies. The images here are sort of a brief overview of the so-called fusion biopsy, whereby pre-biopsy MRI detects a lesion as well as delineates the prostate gland. And the images are using a sophisticated software is fused into the real-time TRUS image. The potential downfall of this is that there is a segmentation error, although in literature that's being reported into being quite accurate. And the additional advantage of fusion biopsy is that the procedure is principally TRUS-based. So anyone who is familiar with being able to perform TRUS biopsies is ultimately familiar with the process, and it also can be incorporated sort of within the regular workflow of the outpatient performance of biopsy, as well as potential for sort of concurrent systematic biopsy that can be performed at the time of targeted biopsy. Other strategy includes cognitive, which refers to sort of direct mental registration of the suspicious lesion into the real-time TRUS, which of course can be operator dependent. And there's a inboard strategy where perhaps offers the most opportunity for direct targeting. The needles are directed while the patient remains in the MRI gantry, but of course this entails a sort of a prolonged procedure time, and not everyone finds this necessarily comfortable. Now the question is there a superior strategy to targeted biopsy? A recent systematic review actually looked into this. They synthesized about 40 studies looking at a variation of clinical population, as well as the heterogeneity and the way they defined a clinically significant cancer. But when it came to detecting overall cancer, they detected significant difference in sensitivity favoring the in-bore strategy compared to cognitive. But when they limited their sub-analysis to the outcome of clinically significant cancer, they didn't find any difference in sensitivity among the targeted strategies. But again, drawing meaningful conclusions out of systematic reviews, especially in the targeted prostate biopsy literature, is that there's quite a variation in the population that is being studied, as well as what they defined as a clinically significant. And notably for this particular study, there were maybe only 4 studies that looked at comparing the 2 different targeted strategies. Most studies actually used only a single targeted strategy, making comparison even more difficult. But regardless of the targeted strategy being considered, there has been emerging evidence in the background that, my apologies, with the onset of the systematic review, there was also a randomized controlled trial that was published recently, further demonstrating there was no difference in targeted techniques when a group of men with clinical suspicion were randomized 1:1:1 to fusion or cognitive or in-bore strategies. This was a relatively underpowered study. They had recruited more than 600 patients initially, but limited the targeted biopsy to only men with a suspicious PI-RADS version 2 score, so anywhere from 3, 4, 5. And as a result, because they didn't find any significant difference in rate of detection of any prostate cancer or target or significant prostate cancer, the conclusion was that because of the underpower, you can't draw a meaningful conclusion out of this, unfortunately. In the background, though, that regardless of the strategy that is being pursued, the efficacy or the performance of targeted biopsy was starting to outperform your traditional systematic biopsy. And this is a systematic review from the Dutch group in 2015, accumulation of 1,926 men with clinical suspicion of prostate cancer across 16 studies. And the significance of this systematic review is that they limited the inclusion of studies to looking only at men who underwent blinded sequential biopsy. So they received a MRI targeted biopsy followed by blinded systematic biopsy. The important caveat, though, here is that all men who received a sequential biopsy had to have at least one targetable lesion on MRI. But if you're looking at the sensitivity of the targeted biopsy and detection of all prostate cancers, any significant cancers, there was a generally improved sensitivity in detecting those in comparison to the TRUST systematic biopsy, which was being performed with the 8 to 12 core sampling. And the sensitivity for detecting insignificant cancer was reduced, indicating it has the ability to also minimize the detection of indolent cancers. The systematic review was sort of a first attempt at summarizing the benefit of the targeted biopsy, and the studies that made it to the analysis were relatively small scale and retrospective in nature. And the subsequent publication in JAMA was a sort of an important landmark trial that confirmed the performance of the targeted biopsy in men with clinical suspicion of prostate cancer. This is a JAMA article in 2015 using a prospective cohort over 1,000 men in Maryland, enrollment from 2007 to 2014. And these eligible men, a few of which were also biopsy naive, had at least one targetable MRI lesion. They underwent blinded, a sequential targeted and systematic biopsy, enabling comparison between the performances too. Essentially, they compared the histopathology between the targeted and the systematic biopsy group. And the notable findings here is that the targeted biopsy enabled 30% increased detection of the so-called high-risk cancers, which the authors here defined as Gleason score greater than, equal to or greater than 4+3, as well as a significant reduction in their in the number of detection of low-risk cancers, as reporting 17% reduction. This is the cross-tabulation of the histopathology between the targeted biopsy and the systematic biopsy. And what's interesting here is that the targeted biopsy, it can miss the diagnosis of cancer. And of the ones that were missed, if you were to add the systematic biopsy to that, that would have actually resulted in more than 103 cases of prostate cancer being defined. But if you're looking at the numbers that are actually being detected, majority of them would be considered low risk, and these would be considered over detection, whereas a relatively small number of them would have been considered high risk, which the authors, when they created the definitions for the risk stratifications, that these are the ones that would have needed aggressive treatment on detection. The idea that targeted biopsy perhaps provides better, characteristics to the tumor biology, the targeted biopsy, the overall concordance rate between the two biopsy strategies was about 69%, which was moderate, but the targeted biopsy upgraded no cancers or low risk cancers to the higher risk in 67%, which was significantly higher than 41% upgrade with the systematic biopsy. And the study was also significant in that they compared the histopathology against a whole mounted radical prostatectomy specimen on the subset of population they enrolled in, and sort of adding to the value that perhaps the targeted biopsy better discriminates significant malignancy. 60% of them examined under whole mount analysis were intermediate to high risk, whereas relatively fewer were intermediate to high risk using systematic biopsy. And when they actually dichotomized the result from no cancer or indolent cancers to the outcome of detection of intermediate or high risk prostate cancer using radical prostatectomy specimens as the reference de facto gold standard, the performance of targeted biopsy was significantly better than standard biopsy or the combined biopsy. So this was an important paper that sort of established the effectiveness of targeted biopsy and its ability to discriminate clinically significant cancers while minimizing the detection of indolent cancers. But the limitations leading up to this point have been that there has been inconsistent reference standards being tested. And for example, the studies using TRUST, we know that it can miss up to 25%, up to 20% of the diagnosis, and hardly represents the de facto gold standard test against which the diagnostic performance is being evaluated. Using radical prostatectomy specimens as a gold standard would also be problematic in that it incurs the risk of selection bias, and it's tribute to the idea that the men ultimately undergoing radical prostatectomy with evidence of prostate cancer is fundamentally different from men presenting for their initial visit with a clinical suspicion of prostate cancer. Therefore, the group in UK actually suggested perhaps a gold standard way of detecting prostate cancer would be a transperineal saturation biopsy. This is a technique where they obtain prostate tissue every 5 millimeter increments, and they were able to model this using a software where they combined 107 consecutive radical prostatectomy specimens. They created a artificial threshold of detecting with greater than 95% sensitivity a tumor volume exceeding 0.2 milliliters or 0.5 milliliters. And as a result, they were able to create a definition of clinically significant disease, particularly for tumor greater than 0.5, which would be defined as a maximum cancer core length exceeding 6 millimeters and Gleason score equal to or greater than 4+3. And this exact definition of clinical significance was applied in this landmark PROMISE trial. This was published in Lancet in 2017, looking at a prospective biopsy-naive men, a total enrollment of 576. This spanned across 11 sites in UK. whereby every biopsy-naive men with clinical suspicion of prostate cancer complete a multiparametric MRI in accordance, consistent with the minimum anatomic and functional acquisition, as well as followed by the blinded 10 to 12 systematic biopsy and the transperineal biopsy, which they postulated was the gold standard. Notably, the median time between the MRI and the subsequent biopsy was 38 days. And it should be noted that the men undergoing MRI didn't actually undergo dedicated targeted biopsy. They were simply screened with a multiparametric MRI. This is a summary of the diagnostic performance of MRI compared to systematic biopsy. And across the board, it had improved sensitivity and negative predictive value. The authors actually used three different definitions of clinical significance, and the relative performance of the relative performance of MRI at discriminating these so-called clinically significant tumors are far better than in the trust biopsy, with the caveat that these were men that were not ultimately offered targeted biopsy. They were simply offered multiparametric imaging. And they conducted a sort of interesting hypothetical diagnostic pathway. They limited the analysis to ones that with a suspicious MRI, so graded PIRS 3, 4, 5, and they reported that almost 30% of them at that point would not be candidates for biopsy. Using this sub-analysis, they actually created two hypothetical pathways. Pathway number one would be men screened with MRI, and if they do have a suspicious lesion, they would be offered a non-targeted trust biopsy, whereas the alternative pathway would be biopsy-naive men with suspicious MRI would undergo targeted biopsy. And with the latter pathway, while you accept the probability, while you accept increased detection and overdiagnosis of indolent cancers, you also seeing almost a 20% increase in your ability to detect clinically significant cancers, which was certainly not the case when people with suspicious MRI lesions undergo systematic biopsy. But we can only assume the performance of the targeted biopsy in this situation is just as good as a transperineal mapping saturation biopsy that these authors performed here, because the men they studied actually did not undergo targeted biopsy. So, the question naturally becomes then, do all these MRI visible lesions need to be biopsied? And these were studied sort of in parallel in this pair of randomized non-inferiority trials. The Precision study in 2018 from the UK group, and the Precise, which is our Canadian trial that was published this year. And the hypothesis was that not all MRI visible lesions need to be biopsied. Precision was a New England Journal article. It was a randomized multi-institution trial enrolling 500 biopsy-naive men, and the MRI was performed according to the minimum criteria. And they randomized men to the MRI arm, whereby the biopsy was offered only to men with suspicious lesions, so PIRS 3, 4, 5, and randomized men to regular systematic 10 to 12 core biopsy. And their primary outcome was detection of clinically significant cancer, in this case defined by Gleason 3 plus equal to or greater than 3 plus 4 disease. The twin to that was a Precise trial that was conducted in Canada. This was multi-institutional, including Vancouver General contributions from VGH. This was a JAMA article, and they randomized 453 biopsy-naive men. The MRI was obtained per minimum criteria, and only the suspicious men with a suspicious MRI lesion were offered targeted biopsy, otherwise standard 12-core systematic biopsy, and they had the similar primary and secondary outcomes. The notable difference in the Precise enrollment is that these biopsy-naive men additionally had to be risk eligible. They all had to have greater than 5% chance of harboring grade group 2 disease, according to individual risk calculated from the PCP track nomogram. And what they found was that the Precision report, they avoided biopsy in 28% of the men that were randomized. Even higher proportion actually were not offered targeted biopsy in the Precise arm. What's outstanding here is that there was a significant difference in primary outcome. And this was a non-inferiority trial. And when they actually conducted an analysis to see if it met superiority, the results from Precision met criteria for superiority across intention to treat analysis all the way to per protocol analysis. They did detect more clinically significant cancers while detecting significantly less clinically insignificant ones. This was similarly the case, although the significance for superiority was not met. Targeted biopsy in PRECISE was at least non-inferior to systematic biopsy, but it did improve the detection of it had a significantly less detection of clinically insignificant cancers compared to systematic biopsy. But the important caveat that arises from this is that what is the implication of harboring a negative MRI in these biopsy-naive men? And alluding back to the data from PROMISE, where they reported a negative predictive value ranging from 76 to 89%, even in the best case scenario, 89% of there's a chance that 11% of negative MRIs or cancers are being missed in those individuals. And the range of negative predictive value here is also reflective of the range of prevalence as a result of conducting their performance analysis based on 3 different criteria for clinically significant disease. And I think the current sort of landscape and any recommendations around negative MRI is weak owing to the lack of follow-up data. For example, Precision, 28% did not undergo biopsy, and unfortunately their follow-up was limited either to 30-day or when the treatment decision was made. But the authors did report that out of those 3 men who had negative MRI and was therefore not offered systematic biopsy, they were not offered targeted biopsy, 3 of them subsequently underwent trust biopsy, none of whom were diagnosed with clinically significant disease. In PRECISE, 37% did not undergo biopsy, and the study actually mandated a follow-up 2-year MRI in these particular population, and we look forward to what the natural history of biopsy-naive men with negative MRI would show. The systematic review looking at a sort of a pool negative predictive value of missing clinically significant cancer in men with a negative MRI was 88%, but this, despite the large accumulation of studies, there was only really one study that clarified a priori the definition of clinical significance. So the effective comparison was not possible. There was a study that published in 2018 actually reported up to a median follow-up of 38 months. They looked at a subset of 659 biopsy-naive men, and when they were not, and they followed them to that duration and found that 5% ended up harboring clinically significant disease. And I'll talk about this data a little bit later. Because we know that a multiparametric MRI, it can miss a small and multifocal tumors. This was a paper by Johnson published in European Urology. And when they defined clinically significant cancer as Gleason equal to 3+4, it actually had a moderate sensitivity and positive predictive value. This was a retrospective study, a prospectively maintained cohort of more than 500 consecutive radical prostatectomy specimens, and the inclusion criteria was that all men had to have a preoperative multiparametric MRI within 30 days of a radical prostatectomy. And they found that the clinically significant cancers tended to be missed in smaller smaller foci, or those that are considered non-index lesions, so not the largest lesion on the multiparametric MRI, or ones that are not considered the most suspicious, as well as multifocal tumors. So we know there are characteristics of tumors, at least on multiparametric imaging, that potentially misses a clinically significant cancers. And I think the idea with relying on multiparametric MRI alone in the evaluation essentially this is perhaps a discussion for another day, but I think the use of other clinical variables is helpful. And the European group in 2017 actually sort of devised this risk model incorporating the MRI findings with clinical variables including log PSA, prostate volume, results on digital rectal exam. And this was also a PIRADS, relying on the previous PIRADS schematic. And actually their ability to detect or discriminate clinically significant cancer in biopsy-naive men was comparable, if not slightly better, than the already available risk calculators, including the ERSPC model. Similarly, in 2018, there was a publication that especially in discriminating clinically significant disease in biopsy-naive men with a negative MRI, the use of PSA density, and age were predictors of harboring clinically significant disease. This was also the study that had published a median follow-up of 38 months, where they found that 5% of missed clinically significant cancers, but they also reported that the diagnosis-free survival, at least from the clinically significant cancer, was 95% at 48-month follow-up. I think in the end, the men ultimately requiring targeted biopsy, in the absence or presence of a suspicious MRI lesion, the question also now becomes whether targeted biopsy alone is enough, and concurrent systematic biopsy should not be performed. And the earlier data from Siddiqui, published in JAMA, reported that not a small proportion of biopsy-naive men who undergo targeted biopsy alone are upgraded to sort of a higher risk category that would perhaps change management with the addition of systematic biopsy to targeted biopsy. And I think this aligns with the overall hypothesis, is that combined biopsy is sort of it improves the detection of clinically significant cancers, and therefore should be considered across all settings. And this was also looked at independently from these pair of European trials published recently. They both offered, the protocol was quite similar. They identified eligible biopsy-naive men. They used the minimum criteria MRI acquisition, and they offered everyone a trust biopsy, at least involving 12 cores. They only offered a targeted biopsy if they have suspicious lesions. And when they did a comparative analysis, the omission of systematic biopsy would have resulted in missing 5% in the French study of clinically significant disease, defined as Gleason score equal to or greater than 3+4. And the subsequent Dutch study reported missing up to 3% of the clinically significant disease. And this point was really hammered home with the the recent New England Journal article. This was a prospective American study from enrollment 2007 to 2019. It was a very large population-based study, included 436 biopsy-naive men, but more than 200 eligible men with at least a targetable MRI lesion received a sequential targeted biopsy, followed by the blinded systematic 12-core biopsy. Again, they did routinely use endorectal coil in this case, but otherwise met the criteria for minimum acquisition standard. And they defined a clinically significant cancer defined as Gleason equal to or greater than 4+3. And across the board, the combined biopsy would result in more detection of cancers across the group. But the combined biopsy actually discriminated less grade group 1 cancer compared to the systematic biopsy alone. This is a cross-tabulation of the histopathology they combined, and specifically, if you were to look at the results of targeted biopsy alone, essentially the ones that are shaded in green are the ones that were upgraded with the addition of systematic biopsy, and actually 16% of the pathology that was defined by targeted biopsy alone were sort of reclassified using the addition of systematic biopsy. But if you look at specifically the numbers within the red box, the targeted biopsy alone would have missed in this population 60% of cancers equal to or greater than grade group 2, typically where potentially the management changes. And the idea that a combined biopsy perhaps that yields the most accurate sort of characterization of tumor biology would be that there was the least amount of reclassification of disease when compared to radical prostatectomy specimens, and that the most changes ultimately came from the systematic biopsy pathologies. So we're beginning to appreciate the evidence that the targeted biopsy does detect more clinically significant cancers while reducing detection of clinically insignificant cancers. And I think as a nice complement to that, it can also be cost effective. This is a group in 2018 that published the findings from PROMISE. They actually devised more than 380 hypothetical sort of diagnostic strategies using the published performance from the PROMISE data, as well as available systematic reviews at the time. Essentially, the red circles here represent sort of the frontier of financial effectiveness. And when you plot it against the proportion of clinically significant cancers that are being detected, and if you actually look at the ones that are forming the frontier, they're the ones that incorporate actually the targeted biopsy in their strategy. Even so, the subscripts that carry the M are the ones that are being offered upfront MRI, followed by targeted biopsy if indicated. The one with the highest diagnostic performance was actually the pathway that offered truss biopsy followed by the transperineal mapping biopsy. But the ones that incorporated targeted biopsy tended to be the more cost-effective solutions. And in this light, the current recommendations, at least from the most up-to-date European Association as well as the National Comprehensive Cancer Network, is that the multiparametric MRI in the least that should be offered to all biopsy naive men before biopsy, and when it is positive, that it should be targeted not on its own, but targeted as well as a systematic biopsy. And again, the evidence supporting whether the negative MRI is safe enough to preclude biopsy is weak at the moment. And again, I think that we look forward to any follow-up data that comes to sort of give us insight into the natural history of these lesions. So in summary, targeted biopsy, regardless of the targeted strategy, improves the detection of clinically significant prostate cancers. And improves the ability to not detect the clinically insignificant ones, thereby perhaps also subsequent to that improving or at least minimizing the risk of overtreatment. Combined biopsy is still recommended to reduce the risk of missing clinically significant cancers when a targeted biopsy is recommended. And again, lack of long-term data to support the omission of biopsy negative MRI. And likely in this scenario is also the use of other clinical variables such as PSA density or prostate volume, which is likely to be of clinical assistance. And with that, I'd like to conclude my rounds and send my gratitude to Dr. Black for, again, his endless wisdom and insight into the topic.